Start with my introduction. Perfect. So yeah, thank you for coming, everyone. Happy afternoon. My name is Christina Muller-Shinn. I work at Mason County Public Health and Human Services. Mason County is a rural um, county in Western Washington. Um, and I've been here at Public Health for 7 years. But I have been doing harm reduction work on and off since 2006. I think I've worked at maybe or volunteered at maybe 5 different Syringe service programs through California, Oregon, and Washington. Um, so I have a very specific interest in meth. This has been something that I've been talking about for several years, uh, mostly because of the prevalence here, the high rate of substance-related fatalities that involve methamphetamine, and also from information I've heard and seen from our participants, including common misinformation, kind of seeing how chronic meth use has affected them, and kind of also noticing this lack of tangible and comprehensive ways that harm reduction providers can help support folks who are using meth. A lot of the majority of harm reduction literature and toolkits kind of don't go much farther than like stop or reduce your meth or like get rest, hydration, nutrition, which are all great things. And we'll talk, kind of talk about some of those. But in developing this and talking with folks over the last few years, just learned really cool, tangible, small tools that both people who are using meth can employ in their life, as well as things and strategies that programs can do, big and small, to help these folks.
Great. Thanks, Christina. It's nice to see everyone. My name is Leyde. I'm an internal medicine and addiction medicine physician at the University of Washington. I practice outpatient primary care, internal medicine, and then I practice addiction medicine in the outpatient and inpatient settings. And yeah, I've had a long-standing interest in methamphetamine and improving care for people who use methamphetamine. And some of my most formative training experiences during fellowship really happened at Syringe service programs. So I'm just really delighted and honored to be here and to be presenting alongside Christina. So with that, we'll get started.
Right. So I am hoping most of the folks here are familiar with harm reduction, maybe very familiar with harm reduction, but we just want to do some level setting since all the strategies we're going to be talking about today are very specific to harm reduction. So one of the definitions you can find from this at the National Harm Reduction Coalition website, as well as the tenets of harm reduction. But harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. Harm reduction to me is something that is just pragmatic. It makes sense. One of the things that drew me to starting to volunteer at certain service programs, which I'll call SSPs, Syringe Service Programs, I could see the difference. We could see the tangible difference we had. We could hear people coming back and saying, you taught me how to use naloxone and overdose response, and last night I saved a life, or these things that we did have led to X, Y, and Z. So for me, it just makes sense. I'd like to kind of like level set or introduce this topic of methamphetamine specifically, because we're talking about this in several different systems, and we heard from the first episode in the webinar, lots of different mechanisms that are associated with like chronic methamphetamine use or stimulant use, but we are going to focus on meth. And sometimes it can be a little, a lot of SSPs might not really know how they fit into bigger systems or clinical settings or kind of other social services. But there's this very salient story that happened, and my participant did give me permission to share about kind of how all of these systems kind of work together and how we can see. So a gentleman, I hadn't seen him for a few months. He came back, and it turned out that he had a infection in his mouth. It was an abscess, a tooth abscess, and that had kind of the bacteria from that had caused endocarditis, which is a very serious infection of the lining of the heart. And then that all kind of led to a stroke. Then he was in the ICU for several months, and is doing really well now. But I think that is just such a kind of perfect example of how oral health, how cardiovascular health, neuro health all kind of work together. And it really is a system level approach. So I think with SSPs and harm reduction programs, there is just so much opportunity for growth and so much room for improvement to integrate these services, like specific services for people who use meth. I also will maybe often say, or you might see it in my slides, the acronym PWUD or PWUM. That stands for people who use drugs or people who use meth. I might also say people who use stimulants, because I think these are translatable through many stimulants as well. But harm reduction around methamphetamine is often talked about in these kind of broad strokes, doesn't really go much further. Kind of a lack of comprehensive, well-circulated resources. There are amazing resources, but I don't see them being as circulated or talked about as much. Yet the morbidities and mortalities associated with meth specifically are kind of often due to these multi-body system failures, a lot of which can be preventable. And that's what's so exciting about this is we can prevent a lot of the things, we can treat things, and that's really exciting that we can do that. I'll go to the next slide.
Great. And from the primary care, in the primary care context, I'll just give you like, I'm sure there's like some primary care docs in the audience. I actually can't see you with my current Zoom setup, webinar setup here, but I'm sure there's some PCPs in the audience, some people who work in primary care, and then lots of folks who don't. So I just want to give you sort of a context of how people are sort of viewing this in primary care. So I asked some of my primary care colleagues here at Harborview and other institutions to just like answer a short survey. What words come to mind when you think about the experience of treating patients with methamphetamine use in primary care? And as you can see here, there's just this real sense of like hopelessness, challenge, difficulty, just like there are no treatment options or limited treatment options. And so one of my big career goals is to really help primary care providers feel better equipped to really improve the quality of life. I see like a heart. Did someone heart that? Okay, great. Thanks for the love. To really like help people, feel empowered, right? To help our patients. Um, so this was a really cool study that my colleague Brittany Blanchard here at UW led. I don't know if Brittany is in the audience, but total rock star, and led this study showing that people who use methamphetamine want to talk with their primary care providers about harm reduction. So both patients and clinicians found discussion of protective behavioral strategies both acceptable and feasible. And clinicians wanted more resources and training because this is nothing we learn in medical school. It's kind of coming up in the curriculum more recently, but like when I was in medical school, we read a paragraph about addiction, and like that was the extent of our education, nothing about harm reduction. So one really powerful quote from Dr. Blanchard's paper is from a primary care patient: "Don't tell them to stop. Obviously, we know what we're doing. We know what the effects are and the consequences. I think they should do more. I think they should think more about what they can do." So we really owe it to our patients to educate ourselves and to be able to do more. And I would argue, like, we already have a lot to offer in primary care, right? I put a lot of things in this diagram. I'm aware that like not every primary care clinic has this. Like I put oral care in there because some FQHCs have dentists. I don't. I'm jealous. But right, we have primary care. We have like primary care providers, nutrition, oftentimes, usually social work, pharmacy, behavioral health is sometimes integrated. We have access to specialists, peer support in my clinics, at least. Like there are a lot of things we already have, and really one big thing I want to impart is that really addressing these social determinants of health is, I would argue, like one of the most important things we can do, right? Like hooking someone up with housing resources is powerful harm reduction for methamphetamine. And Christina shared with me that in report looking at substance use in Mason County, where Christina is, about 20% of SSP participants asked for a medical or dental referral. So clearly, like your patients, want to talk with you about this, and I think we can be helpful. And we can do a lot more too. So while offering harm reduction advice, dispensing naloxone, drug checking, providing safer use equipment is not something traditionally thought of as being offered in primary care, it absolutely can be done. And these are actually all things that we've started to offer in the clinics I work in. Of note, Washington state law now allows for healthcare organizations to pass out harm reduction equipment, which is like so amazing. And under the really phenomenal leadership of Tom Fitzpatrick, countless others at UW, including Celeste Kohler, like a really amazing medical student, group of medical students, we're starting to pilot this in Harborview clinics. So we're passing out safer smoking kits, safer injection kits. And I have to say that I've been blown away with how receptive patients are to this and how much it really adds to the therapeutic alliance. Because it's one thing to say like, oh yeah, like harm reduction, I'm cool with that. It's another thing to like hand them a bubble, right? I will also add that like this is not at all a replacement for connecting people with harm reduction organizations and SSPs because they have such a wealth of knowledge. Also, like in our small pilot, right? We don't have like the funding is limited at this point, right? So we give out like one bubble per primary care visit, right? That's not going to like sustain someone. So we always try to connect people with SSPs and harm reduction organizations. All right. So I wanted to give you sort of my approach for talking with patients uh, about harm reduction and sort of like more generally how to talk to people who use methamphetamine and other drugs in primary care. So number one is greet people warmly. So there is so much stigma and discrimination globally in our community and also definitely in healthcare. And so like, right, like traditionally patients who use drugs have been treated really, really poorly in healthcare. So it's like a miracle they're there and like you should thank them for coming. Second, we want to ensure comfort. So these are some things that we like to give out, snacks, nutritional supplements, either warm blankets or an ice pack, like depending on if people are overheated or if it's like a cold, rainy Seattle day. And then it's really nifty to keep like these fidget spinners on hand, especially for people that like might pick their skin or have some more like psychomotor symptoms or hyperactivity. And then other tips include addressing their needs first. So sometimes I see people get into trouble with this where they get so excited to talk about harm reduction and substance use that they actually like forget to address the main reason the person is there. So like if they come to you because they have knee pain, like you should address that first, right? And then asking permission, right? To then maybe talk about their methamphetamine either at that visit or like maybe at a later visit. Um, okay, another quote from Dr. Blanchard's paper, just be honest and truthful and show that you care. That goes such a long way. So once there is sufficient engagement, I really like to take a respectful, non-judgmental history. And in harm reduction, it's really important to acknowledge that drug use has like pros, definitely has pros and cons, right? And it's also like really clinically valuable information to know the reasons people use. So this is what I commonly hear from my patients. So helps with safety on the street at night, keeps me alert to work 3 jobs, treats pain, treats ADHD, melts away internalized homophobia during sex, helps during sex work, feels really good, right? That makes sense. And then a lot of people use it to sort of like counter the side effects of fentanyl. And then also acknowledging the cons, like what do you like less about methamphetamine? What problems, if any, is it causing for you? Impacts on relationships, legal system involvement, impacts on health and well-being, physical, safety, impacts on life goals. And then I'll just acknowledge, like, for some people, their methamphetamine use is not causing problems. Like, it might have health risks, just as like prescribed stimulants do or something, but for a lot of people, it's not causing problems. And about 50% of people who use methamphetamine have a use disorder. So not everyone who uses, really meets criteria for having an addiction. Okay, next I like to take a history and learn about their use, and then also about any goals that they might have. So I don't have the luxury of like a 2-hour ASAM assessment, nor would my patients. Most of my patients like really want to like sit through that. So these are some just high yield questions that I've thrown up here that I often ask about. So just open-ended, right? Tell me more about your methamphetamine use. And then I'm using the MI skills like reflecting, affirmation, summary statements, all of that throughout. How do you usually use methamphetamine? And also, like, when is the last time you injected, right? If we just say, how do you use it? And people say smoking, we might miss out on a really valuable opportunity to talk about safer injection practices. What other substances do you use? What do you do to use methamphetamine as safely as you can, right? And that is a nice way to start the harm reduction conversation, to learn from your patients and also to affirm them. One of my favorite things to do is ask about naloxone, like, hey, what's been your experience with naloxone? Have you ever had to give that? And then really affirming that, like, our patients are out there saving many lives, like sometimes way more lives than we like save in a week, right? So important to recognize that. What happens when your body gets too much methamphetamine? Um, oh, thanks for the clap. It's so funny. It's like floating up from the bottom of my screen. So yeah, thanks. Okay, what health problems, if any, is methamphetamine causing for you? And then what would you like to see happen with your meth use in the future? For some of my patients, that's going to be using more safely and continuing to use it the same amount. Some people want to cut down, some people want to stop completely. And like all of those goals are worth supporting. Okay, so when I'm assessing a patient, I also really try to hone in on a few key systems to see whether the person is having health issues related to their use. And I'll just say this figure is a bit simplified and that meth can affect like way more body systems than I've put on this slide. But these are like the big categories I keep in mind when I'm doing review of systems, examination, and a lab workup. Um, and the big, like all of these are important. And the big two buckets of things that tend to end people's lives are cardiovascular and neuropsychiatric toxicities, which are in the yellow and things I want to sort of highlight during this presentation. So I don't think I'm going to read these out loud because we're already behind, and I want I want to give Christina the full amount of time. So you can just take this all in. I'll just say, I guess one important thing for cardiovascular is that we think that both the sympathetic sort of like being in that hypersympathetic state for a long time, like elevated heart rate, elevated blood pressure, that causes cardiovascular disease, and also the direct toxicity of methamphetamine itself and release of reactive oxygen species also leads to cardiovascular disease. Okay, so keeping in mind all the different parts of the body that methamphetamine can affect, here's kind of a standard workup I'd offer to patients. I put offer in all caps because like I don't think it's a good idea. I mean, some patients just want it all up front, but for someone who's like kind of just entering the healthcare system, kind of doing all this at the first visit might be too much. So use your judgment there. Some of the things, vital signs, obviously, physical exam, paying attention to oral health, cardiovascular, dermatologic, and then a neuropsych exam. Testing, I get basic labs to get a sense sort of their nutritional status, infectious disease screening, so hepatitis B and C, HIV, syphilis, gonorrhea, and chlamydia. Cardiovascular, so I have started to offer an EKG, like a heart checkup is kind of how I would frame it for patients. In this example, you can see left ventricular hypertrophy, which we commonly see, and it can be a great conversation starter. Like, hey, I'm noticing these changes. Is that okay if we like talk a little bit about this? And then A1C to test for diabetes, just to get a sense of their like general cardiovascular risk as well. And then a screening BNP, which is a good screening test for heart failure. And then if that's abnormal, or if they have clinical signs and symptoms of heart failure, getting an echocardiogram. All right. Next I want to move into preventing and treating life-threatening chronic toxicities, so cardiovascular and neuropsychiatric. So starting with cardiovascular, it's the stuff we talk with patients about in primary care all day. Exercise, diet, addressing smoking, low-dose aspirin if indicated, and then a statin. My approach is to definitely offer a statin if it's indicated for primary or secondary prevention. There are some like really interesting animal studies showing that statins might be especially like neuroprotective, especially atorvastatin, which crosses the blood-brain barrier a bit better than other statins. And so there are some people I think who are like prescribing all their patients who use methamphetamine statins. I would like love to see that replicated in humans before just prescribing it to anyone. So my expert opinion, what I do is just to consider stimulant use as a cardiovascular risk factor when conceptualizing cardiovascular risk, and to maybe like use it as a tiebreaker, right? If they're at that certain sort of like 10-year risk of having a major cardiac event, like using that as a tiebreaker to say like, hey, maybe we should start a statin. So I'm not starting in my like otherwise healthy 18-year-olds who use methamphetamine, right? I'm thinking about for people with other risk factors. And then for treatment, for heart failure, standard treatment, beta blockers are fine. That myth has been debunked. You can use beta blockers. Hypertension, standard treatment, and like make sure to treat elevated blood pressure in your patients who use methamphetamine. Neuropsychiatric toxicity, really can't understate the importance of exercise, sleep. We talked about statins and acetylcysteine. I don't think the data is that great. I don't prescribe it, but low risk. And then for treatment, second generation antipsychotics for chronic psychiatric symptoms. There was a really excellent ADA talk by Jonathan Buchholz that you can check out on YouTube to learn more about this. And then there was a really interesting study that came out recently from Philip Coffin and crew in San Francisco talking about low dose olanzapine packs after discharge from the psychiatric emergency services for self-treatment of acute agitation. So like 5 milligrams of olanzapine PRN overamping, and they found that that was associated with reduced presentations to psychiatric emergency services. And I believe they're planning on studying that more rigorously in the future. But I have started to do that. I think it's really compelling. I'm going to skip this slide because there are two excellent webinars coming out about sexual health and people who use methamphetamine. The big point is like test for STIs, treat them, vaccines, PrEP, and then doxy-PEP, which is kind of a newer thing, right? So providing doxycycline, considering doxycycline after sexual encounters. Okay. Next is promoting skin health. So delusional parasitosis is a common problem. It's very, I think, really challenging to treat. And I think there are lots of different ways to approach it. I like to really like validate the distress that's going on. Exploring methamphetamine's role, so not telling someone it's the meth, like that's why you think you have bugs on you, but not saying that, but just like, oh, like what do you think? Like, what role does methamphetamine play in this? Like, could it be, is it making it worse for you? Like, just kind of getting at that. Antipsychotics can be helpful. And then those fidget spinners and occupying your hands in other ways. I'm going to skip over this for the purposes of time. And then, yeah, I'll just say too, like connecting people with wound care and connecting people with community organizations. Okay. Christina is going to talk a lot about oral health. For the clinicians on this webinar, I'll just say like know something about it. Like this is another thing that we learn nothing about in medical school. This is a great Curbsiders episode that really goes through like dental emergencies and when you might consider prescribing antibiotics. To sort of like tide people over while they're waiting to see a dentist. So check that out. And then clinicians can consider getting like fluoride varnish. And that's something that some of the docs in our clinic are trying to explore. Obviously, we want to just like get people to the experts, to the dentist, but what are the things we can do to minimize harms while that's happening? Okay, and then some people are going to want to discontinue or reduce their use, and ADI has some great material on this already, so we're not going to take a deep dive, but I'll just say that despite the prevailing thinking that we can't treat methamphetamine use in primary care, like we can, So the things in orange, I think we can do, right? Like we can learn more about MI and cognitive behavioral therapy. We can prescribe bupropion and naltrexone and mirtazapine. Prescribed stimulants is something I'm like really interested in. The American Society of Addiction Medicine guidelines suggest that that should really be done by specialists, addiction med or addiction psych, or people with commensurate like time and experience and in a way that we can closely monitor patients. But I think that's a sort of like new frontier in methamphetamine use disorder treatment. Okay, and then I want to close by just acknowledging the fact that we order stuff all the time in primary care or tell people to do things and then it doesn't happen. And if it doesn't happen, it doesn't really matter, right? So remember, methamphetamine is really neurotoxic, right? So a lot of people have cognitive dysfunction. So here are some tips I've learned over time. Just like be flexible. If people come 10 minutes late, try to see them. Find supports for people who can like remember the things you talked about in the visit. Simplifying the med regimens, helping with transportation, writing instructions down. So there's some evidence that methamphetamine affects auditory learning more than other ways of remembering things, other learning styles. So really like writing things down, developing a network of specialists who get it and will treat your patients well, and then leveraging community organizations and connecting people with harm reduction. So I'll turn it over to Christina.
Thank you. And I'm seeing the harm reduction definition slide still. Perfect. Awesome. Thank you so much, Sarah. So much information. What I really took from that is that people who use meth can be diagnosed with early heart failure. They can take medications and be treated and prevent the escalation of, heart failure from progressing. And that's just really exciting. So kind of moving into the Syringe service program, harm reduction, programming aspect. I think, as I said before, there are so many opportunities, big, small, free, cheap, expensive and big, to implement strategies specifically for people who use meth. And again, I just wanted to share how relevant that is. So every other year, ADAI does very comprehensive health surveys with the Syringe service programs in Washington State. And in 2023, 97% of the participants who were interviewed, I think there were 60 participants from my program who were interviewed, 97% of them have used meth in the last 7 days. And then going further, we asked, how many days did you use, methamphetamine? So 72% of those folks had used meth 7 out of 7 days. That's pretty significant. I would definitely say that methamphetamine is probably one of the most prevalent substances that folks in my community use, maybe tied with alcohol, but it really is something that we need to focus our attention onto and really explore more. I want to start off, before I get into it, by thanking Lindsay Palmer, who is a clinical dental hygienist at Benton Franklin Health Department. I was so excited to speak with her, and she gave me a lot of resources. So I did use some of her materials here, and I just really wanted to acknowledge that. And I also really want to acknowledge and thank the participants of my program who have talked with me over the years so much about meth and harm reduction and has given me great feedback. And they also presented in this presentation. They participated. I got a lot of quotes from folks, and people were really excited to be able to participate. And I also want to say, like, regardless of program size, low budget, volunteer-based programs, mutual aid programs, to nonprofits and clinics, to public health departments, there are so many different ways to support the health and wellness of people who use meth and stimulants in general and help improve quality of life. And again, I want to echo what Sarah had said, that a lot of people who use meth feel pretty fatalistic about their health. They kind of expect to maybe lose their teeth or expect to have cardiovascular issues. Folks are really eager and excited to learn what tools they can use to kind of improve their quality of life. They get really excited about it. So I'll just start with that. You can go to the next slide. Oh, do my thing. So this is a very, very intense looking slide here. But there are I am working on developing like an educational resource that will go down on this. But these are some very specific mechanisms that lead to a lot of the issues that folks who kind of chronically use stimulants experience. Oral health and stimulant use can contribute to dental issues in a lot of different ways. One of the things I think is really important is how much oral health and dental issues really affect people who are using. By far, the highest referral that I'm asked for at my program are dental referrals. So I think this is something that is really affecting folks' quality of life. It can also cause and induce like embarrassment and shame when we have kind of like visible broken teeth or teeth that are rotting, cause that shame, but it also can be kind of like perceived as an identifying factor for somebody who uses meth in job application or like in job interviews or kind of any day-to-day activities that they have. And that can kind of experience that person to encounter more stigma, kind of more trauma in their life. So I'm going to kind of read off some of the biggest contributing factors. There are more, but these are kind of some of the main points I wanted to focus on. The biggest one is dry mouth, really severe dry mouth. So one of the ways that this kind of works in our body is and I'm going to see if I can say this word correctly, sympathomimetic. We're going to go with that. It actually decreases saliva production in general. And saliva is one of the most important factors that we have in our mouth to protect our teeth. So it, washes away and neutralizes acidic foods or drugs. It can help us with digesting food and with like really absorbing nutrients, etc. And can lack of saliva just prevents that neutralization of acid and washing away of bacteria. So cavities can form really rapidly. The next kind of biggest contributing factor is just the general acidic nature of meth vapors, both from smoking it and snorting it. Snorting it was something new that I learned. I didn't know that snorting drugs could affect oral health. Meth vapors have a pH of maybe around 3 to 5, and cavities start to form below the pH 5 mark. So one of the things that happens if we are smoking meth over and over is our teeth just aren't getting that time to kind of like heal and to get reprotected. So when we have low mouth acidity, this can contribute to the demineralization of enamel, leaving you vulnerable to decay, increases sensitivity and brittleness. Another thing is methamphetamine specifically is a vasoconstrictant, which means it reduces blood flow. And that can cause a lot of issues paired with nutrient deficiencies that are common with folks who are using stimulants and a few other issues. This can really kind of end up with reduced tissue healing. So if we end up having sores or if we have a gingivitis, it can kind of escalate. So that's just one of the things that kind of causes that tooth loss and causes just infection in general. I think it's like our ability to not really heal infection, and infections can spread really quickly. And then there are also some kind of associated, I'm calling them like associated common behaviors that people who use stimulants might do. So definitely not everybody who uses stimulants will have behaviors like this, but it is pretty common. One of this is kind of frequent snacking of like sugary foods, methamphetamine. One is a appetite suppressant, so people don't eat, which is one of the other reasons for nutrient deficiencies. People don't eat very much or don't really have much of an appetite, but people do like sugary foods and sodas. And so this kind of frequent snacking, similar to the acidic nature of the meth vapors, is just kind of continuously kind of demineralizing that enamel and not letting it heal. Bruxism is a term that's like tooth grinding. So this can be really kind of severe with with methamphetamine use, that wears down the enamel, it can fracture teeth. Poor dental hygiene in general can lead to rapid decay, gum infections, kind of a lack of like stimulating the blood flow to your teeth. But I also want to really highlight the lack of access to dental care. It's not always a personal choice to not seek care and seek all the preventive care and x-rays that we, could be doing. I live in a very rural area. We do not have great access to dental care that accepts state insurance, right? And so this is a huge thing. We have one FQHC that has dental care that I send people to, but that's a half-hour drive to an hour drive, depending on where you are. And we cannot also ignore the effect of stigma that a lot of people who are accessing any type of clinical services experience. So again, folks are really, really afraid to seek care, really, really, really afraid to seek care. And I think that is a huge impact. We see this with also reasons why people aren't, going to primary care doctors until it's an emergency. The cool thing is there are some very tangible strategies to kind of reduce the harms associated with this. So with dry mouth, there are many things we can play. I have some fun pictures at the end that kind of show some of these things, but there are many kind of products available to promote saliva production. So there are these like saliva substitutions or like substitutes or mouthwashes, mouth sprays. There are these little mouth sprays that you can kind of spray in your mouth 5-6 times a day, and that will just kind of help prevent that dry mouth from happening. Another thing is kind of using gum, mints, other types of things that will chew, and that also helps promote saliva, specifically with xylitol. So like here's an example of some xylitol gum that I have. Xylitol specifically kind of helps with additional protections around this. But I do have to shout out that xylitol is very, very, very poisonous to dogs and maybe other animals. And just to make that really clear. So on my gum, I have this like very poisonous to dogs. Be very careful. So like, if anybody, it's a reminder for myself to be careful with what I do when I toss my gum out. Electrolyte supplements are also can really help kind of promote saliva and a lot of just general well-being. The acidic nature of meth vapors. So it takes about 20 minutes after smoking for that kind of protections to come back. And there are things we can do about it. So one of the cool, and this, what I love about this is like kind of cheap, free, very easy, or like very inexpensive, is to simply rinse your mouth out after smoking. You can use a mouthwash, especially one that has xylitol in it, but you can even make a very simple mouthwash yourself using like a teaspoon of baking soda and water, and just swishing your mouth out and rinsing that really well after smoking. I mean, this is something that like, I just had this at my house. $1.50. You can buy them on food stamps. This is a tangible thing that people can actually do. I talked to one of my participants and I was like, oh my God, I just learned this new thing. And they were just like, whoa, really? Like I could do that. That's easy. So that's cool, right? Another thing to do is just to continue, ideally people would be going to the dentist once or twice a year and getting fluoride treatments. But as Sarah mentioned, even in primary care, kind of any provider, it can be a dental hygienist or an RN or something, they can get trained to do these kind of like on the go fluoride treatments, by these little packets of fluoride. There's these little brushes. So folks can actually do like quarterly fluoride treatments. I see so much opportunity for street med teams, for other, FQHCs, other programs that might have kind of a medical staff to be able to do this. I mean, I can just see us like going into the camp and, spending a couple of minutes with each person, just doing this little fluoride treatment. That's a big impact. Like rinsing your mouth after smoking, maybe waiting an hour between smoking sessions, doing those fluoride treatments. Those are big impact things that people can do. Regarding the tissue healing, there's just a lot of things to promote general wellness. So having high protein and calorie foods, eating before using water electrolyte supplements. I also am a big fan of nutrition shakes, which I will talk about later, just to kind of as an easy way to get it. And I'll skip just again in time to the next one. Oh, another thing for the bruxism is like getting a mouth guard or even like something to chew on, like a chew toy, to use throughout the day. And you can also get, for fluoride, you can get a prescription of a higher dose of fluoride toothpaste. So I'm assuming primary care doctors can do that. I get these prescribed from my dentist, but it was pretty cheap, and this can also help contribute to that. I'm not going to spend a whole lot of time on this one, but sometimes it's like, why do we care? Like my mouth, my teeth might be falling out. That sucks. But like, what are the actual like real dangers of untreated periodontal disease? And first, to back up a little bit, periodontal disease is kind of like the end stage. So first we get like gingivitis or like kind of infection, swelling of the gum tissue. And that's something that is treatable. That is something that we can identify early and do things to help promote that. Periodontal disease is when it has developed so much that it actually is getting into the bone. So that's a different thing. The bacteria actually changes once it gets into the bone. And this has a very direct cause and effect relationship with heart attacks. So there's a lot of cardiovascular issues, chronic inflammation, bacteria that can travel. As I mentioned in the story, this can also lead to like endocarditis, stroke, etc. There are also a lot of pregnancy complications that are associated with periodontal disease. And some of the cytokines that kind of can become from this bacteria once it gets into the bone, that can actually migrate to the placenta. So there's a relationship between untreated periodontal disease and low birth weights, stillbirths, etc. It can also exacerbate cancers, so that gum disease can actually travel throughout the body and worsen pre-existing cancers that are already existing, and also just have co-occurring complications with a lot of other things, diabetes, cognitive decline, respiratory disease, etc. Some of the strategies for here are really just early diagnosis. The only way to diagnose periodontal disease is getting an x-ray with like periodontal disease charting, which is not accessible for a lot of people. Periodontal disease is often not painful, so people might have it and have no idea they have it. So we really just need to employ prevention strategies and just, if possible, increase that linkages to dental care. Next slide. Sarah mentioned overamping. There's a lot to say about overamping. It's not cut and dry like an opioid overdose. And it's kind of more complicated to say, but I think one of the things that really blew me away when I started doing this work in Mason County was the sheer number of people who have been using meth for so long and literally do not know that you can have a medical emergency that can lead to death from meth or stimulants. But there are some things we can do. Most of it is a medical emergency, so people, need to be able to identify the signs and get to, the emergency department as quickly as possible. But hyperthermia is actually one thing that we can do something. So body temperature can get really, really high when using stimulants. So we can offer cold packs, like instant cold packs, and also just general health, water electrolytes, etc. Next distro has a really amazing, very thorough resource guide on overamping, kind of prevention, other things to do. So I suggest looking at that. But I had a really funny quote that I wanted to share, which is funny because my mom is watching this webinar. So hi, Mom. But I was asking folks, like, how do you use these supplies that we give out? And this one participant said, she goes, well, my husband and I almost always do a shot of meth right before we have sex, like right before. So our bodies get scary hot. It'll make temperatures go up real quick. So I keep the stuff you give me by the bed. They actually built a shelf like right next to their bed. I keep the stuff you give me by the bed, and I'll take an instant cold pack and use it against my face and body for 15 minutes. It really helps me cool down. I never would have thought of that on my own. So much opportunity to engage our folks on, the different ways that overamping can present, the things we can do. And yeah, next slide. I'm not going to touch on this because we're kind of behind, but just it is important to engage folks who use meth on overdose symptoms, opioid overdose symptoms. Cross-contamination happens. People can be at risk. So I think we'll hear more about this in the next presentation on drug checking. So I will move on. All right. So supporting kind of concurrent body issues and systems, there's actually a few items that I think just pack a really big punch and kind of can help support all of these systems that are being affected. Protein shakes are one of my number one requested item. They're easy to eat. They're great for people who have no appetite. Sometimes people don't eat for days when they're on methamphetamine. And this is something that folks can actually kind of get down. I keep talking about electrolyte packets. I love to give those out. Those support so many different things. And a note on giving food. So, poor nutrition just affects a lot of things and can't, is difficult for healing. But just a note to, make sure that we're getting soft foods so that people who have tooth pain or lack of teeth can actually digest it. So soft Nutri-Grain bars, the little like chicken or tuna salad snack pack with crackers are a huge hit, and water as well. A lot of harm reduction programs, we know a lot about wound care and just like hygiene things, but I think preventing wounds from starting by giving ample hygiene support. The wet wipes that I give out are also one of my most popular things. And just another thing to mention is, stimulants can affect our body temperature and our regulation, but it can also kind of, substance use in general, or like being under the effect of substances can sometimes prevent us from really like being aware of what's going on. So people might nod off in extreme cold and, experience frostbite. So it would be great to include protections for severe weather. A lot of folks who are unhoused use methamphetamine, as Caleb mentioned in the kind of first part, that, a lot of people use methamphetamine to stay safe or due to like camping restrictions and all of these like sweeps that are going on. There isn't a place that people can actually be, so they just walk around, and that leads to like a lot of feet issues and just kind of general things. So there's a lot of things we can do for severe weather protection. You can move on, please. I'm just going to do real quick. I'm almost done here, but I kind of wanted to, one, talk about the mechanisms, the specific mechanisms that kind of contribute to morbidity and mortality with methamphetamine specifically, but also kind of then changing gears to what can we do on a programmatic level. So there are a lot of things that we can do for free, which is conversation and education and asking questions using resources that are already there. Again, we can talk about tools they can use, and just kind of having it be an open space where they can ask questions and we can provide information. As Sarah mentioned, people are really eager. They want to know. They are really excited. So it's great to spend time. And you can do next steps. Okay. So I now have broken it down to kind of like relatively cheap, relatively easy, not always cheap, not always easy. But there are a lot of supplies that we can get for meth specifically. This is very much not a comprehensive list, but like those instant cold packs, nutritional support, ample wound care supplies. One of my, I think that's important is if we have people with chronic wounds, that we're actually giving them enough wound care supplies so that they can change their bandaging every day. If I have a chronic ulcer or something big and you give me one gauze roll, that's one day of bandage changing and what's next. Same thing with some of the nutritional support. I know that a lot of programs cannot fund this. These are expensive, but one nutrition shake is not going to change somebody's health outcomes, but giving someone enough where they can have them throughout, the week can actually, make a bigger difference. And there are other things that I think programs can do to help people who use drugs advocate at the doctor. So like what questions to ask, that actually might be on my next slide. No, maybe not. Another thing, well, we'll move on. I'm not, again, going to talk much about kind of like injection alternatives that is a very emerging strategy. This is some highlights from a paper ADII posted on safer smoking supplies specifically. A lot of people who use methamphetamine smoke their drugs and do not inject, and have historically not found that certain service programs were really relevant to what they need. So some programs who are employing these strategies are finding a huge increase in engagement with folks who otherwise would not have. So the Tacoma Needle Exchange was one of the first kind of like pilot projects. They did a lot of research around this. I'm really thankful for everything that they've done to kind of contribute and move us along. But for example, in the 1 year that they started this at one site, they got 64% of their participants were new participants, and they were coming specifically to access smoking equipment. So I just think it's a really great strategy. There are a lot of political issues. You know, a lot of people are not comfortable with utilizing this. For example, like I'm not, my county leadership was not supportive of me employing this strategy. So unfortunately, I am not able to kind of do that. But there is building evidence around it. It's an emerging strategy. I'm really thankful again for this becoming kind of more of a topic. It's hard to be an evidence-based program when there has not been funding and research to support these things. There has historically been bans on federal funding to even do research through syringe service programs. But there's a lot more we can learn, and there's other webinars that you can see about that. Partnerships are really important. A lot of our programs are tiny and we can't do everything. So like I run the Syringe Exchange kind of by myself. So I rely on my partnerships to really expand things. So I have partnered with agencies to do infectious disease testing and linkages to care. I've partnered with lots of agencies to help staff my outreaches. We do a lot of community engagement. I have a kind of provider collaboration group that we started. I partner with the food pantry for our Tuesday Belfair Syringe Service Program site, so people can actually get their supplies from me and then go get a bunch of nutritious food from the food bank. Okay, next slide. And I also just want us to kind of challenge on a programmatic level, are we actually making our program accessible for people who use stimulants? So there are, are we willing to go where people are? So you have see the photo of us hiking deep in the woods for a point in time. I guess you can't really see that very well, but on the left slide, sometimes we have to go deep in muddy, rainy, freezing conditions to access folks. There are, can we partner with street med programs for early diagnosis? So there's a lot of like creative solutions that we can employ. And I have found that funders, so grantors really like these creative solutions, and they like taking a kind of a full approach. Hot tip, I do like to keep my deliverables kind of broad, or like my activities broad in the language in my grant application, so that we can kind of pivot as needed while still making the goals. And I think that's kind of what I have for that. And I know we did not leave for much time. But I also wanted to just mention one more thing that we can do as SSPs. When we're talking with people, a lot of people have a hard time accessing medical care, or like remembering their medications or dealing with that. So, ask, are you working with a case manager? Can they help support you getting appointments? Can someone go to the doctor's appointment and provide advocacy and understanding? So there's just a lot of opportunities and partnerships that might not take a lot of like big systematic changes. And I'll end with that. Thank you so much.
Thank you both so much. This is really wonderful. We do have one question in the Q&A that is maybe easy, maybe not, which is, any problems in the nose from smoking meth?
You're
Christina,
muted, Christina.
You're muted, sorry.
I had an emphatic yes. And I don't have like evidence necessarily based on that. Anecdotally, I've heard a lot of people having issues. Same with cocaine as well. It can kind of eat away at the tissue. Maybe Sarah has more information around that. But harm reduction tool for snorting drugs is, rinsing your nose with saline solution after using, and like, trading nostrils if you're chronically snorting things.
And I have been keeping track of all the comments. There's just some really great and wonderful comments from our participants. just someone said, thank you for acknowledging that walking in the door is a huge accomplishment and should be honored. Someone else said they have a basket of sour candy like Jolly Ranchers. Also, thank you for noting that substance use is not actually a problem for lots of folks. For many people, substance use is a solution. Someone else highlighted that the SKC clinic offers a wide range of dental interventions. Please give patients info April 25 through 28th. I care too. Someone says being stigmatized can be absolutely debilitating and re-traumatizing. Someone else says 10,000% it's prevented me from trying to access care again. And then some nice tips. My go-to snacks when using meth and having no appetite are wet, soft, and cold, applesauce, yogurt, ice cream, and Ensure. And someone else shared these are such incredibly accessible positive harm reduction strategies for oral health. So, as a social worker, I've often recommended some of these like electrolyte tabs and mouthwash, but I've never had the reasoning to back up why these are helpful. So I just wanted to make sure you saw or heard all those because really, really wonderful things that people are sharing. And thanks for putting your emails in the chat. So, and then people, oh, go ahead.
I just want to say I'm really interested in learning more, and I think there's probably a lot of expertise in the room, and I am developing something, both like a handbook for implementing these strategies in programs, as well as like a guide for people who are in active use. So if anybody wants more information, I want to make that publicly accessible as well. So.
And thank you both so much. And just another plug for our future webinars that'll be coming up. Our next one is on meth and drug checking. That'll be March 12. After that, we have one on syphilis, HIV, and hepatitis C. And then after that, we have one focused on men who have sex with men and meth. So really hope everyone can attend those. This recording will be posted to that Focus on Meth page. You can also sign up for our newsletter, which is on that same meth page, which I think we've put in the chat a lot, but I maybe will put in one more time if I get a chance. But just want to say thank you both so much. And oh, is there a speaker bureau on distributing chill out packs via standing order for providers? I see Dr. Leyde's typing an answer. You can also answer.
I don't, not to my knowledge. I think it's something that they are doing a lot in like the San Francisco General Hospital psychiatric emergency services. It's kind of, to my knowledge, they're just like doing that for a lot of people who come in with stimulant associated psychosis, but I don't think there's like a standing order, but that sounds pretty cool.
Any sort of final words from you all?
No, just thank you.
Questions. Yeah, thank you. Thanks for all the kind comments and great information. Thanks, Allison and Caleb and ADAI.
Yeah, thank you so much. This was really, really excellent. Really appreciate your time and effort. Thanks.